السلام عليكم طلابنا الأعزاء، أتمنى أن تكونوا في أحسن حال. Today I will talk about some of the most common benign diseases or conditions affecting the uterus. These include endometrial polyps, Asherman syndrome, Adenomyosis, uterine leiomyomata that are known as uterine fibroids. Okay, starting from endometrial polyps. What are endometrial polyps? These are discrete outgrowths of the endometrium that contains a variable amount of endometrial glandular tissue, endometrial stroma, and blood vessels. They are commonly attached by a pedicle to the uterine wall, and in which setting they are known as pedunculated one, or they are sessile and does not have a pedicle, rather than they are attached by a large flat base to the uterine wall. They can be single or multiple. Their sizes vary from 0.5 up to 4 cm in diameter, and they are characterized by being relatively insensitive to cyclical hormonal changes during menstruation, and thus are not shed at the time of menstrual loss. And this figure illustrates how an endometrial polyp looks like. The one that is attached to the upper to the fundus of the uterus is known as a pedunculated polyp, while that which is attached to the lateral uterine wall, as you see, is a sessile one. And as I said, the pedunculated endometrial polyps are much more common than the sessile. How these polyps can be detected? That is to say, how can these polyps be diagnosed? Of course, using the blind methods, for example, by doing endometrial sampling, blind endometrial sampling, most of these polyps are frequently missed. However, the uterine imaging techniques is very more sensitive in detecting polyps, especially with the use of a transvaginal ultrasonography, and particularly when an intrauterine injection of a saline is added, because this will lead to distinction of the uterine cavity and increasing the demarcation of the polyp, as you'll see from the next slide and the next figure. While hysteroscopy, which is an endoscope of the endometrial cavity, remains the best diagnostic method of any pathology inside the uterine cavity, and at the same time it provides the opportunity for its therapeutic removal, so it can be diagnostic and therapeutic at the same time. Of course, this figure presents a transvaginal ultrasound using a saline as a distinction media, and it is very obvious that the polyp is well demarcated and surrounded by the saline, and it fills about half of the endometrial cavity. This is a hysteroscopic view of an endometrial polyp, and as I said, the hysteroscope provides the opportunity for its treatment at the same session of diagnosing it. Okay, talking about the management of a woman with endometrial polyp. This depends on the age of the woman at the time of the diagnosis. If she is aged 40 years of old or less, they can be managed conservatively. That is to say, they can be followed regularly for the possible development of any symptoms, because they usually are asymptomatic, and these polyps are discovered incidentally. But once they cause symptoms, and the commonest presentation of a woman with endometrial polyp is the development of intermenstrual bleeding, and if this symptom persists for at least 3 months or more, they can be considered for removal. However, women aged 40 years and above, but they are still premenopausal, here the polyps should be considered for removal, because with increasing age, the most common abnormality is endometrial hyperplasia that can be present in just the endometrial polyp tissue. Therefore, their removal can be offered and should be considered for the woman. And in most cases, this can be carried out in the outpatient setting under local anesthesia. Postmenopausally, that is to say, those who have their menses stopped and the polyp is detected incidentally or because of certain signs and symptoms, if it is found, they should be removed. So that is to say, it is mandatory to remove an endometrial polyps in a postmenopausal woman. Why? Because of the increase or the higher risk of hyperplasia and malignancy at the same time, especially those who are on tamoxifen treatment for breast cancer, because as you know that women with breast cancer who are estrogen receptor positive, they are usually placed on tamoxifen therapy because it has an anti-estrogenic effect on the uterus, on the breast, while it has an estrogenic effect on the uterus, and this is why it has a risk of causing endometrial hyperplasia and polyp in about 30% of women. And as well, those who are placed on HRT, especially who are those types that are hormonal, that is to say, not combined with progesterone. Of course, removal is necessary to exclude the remote possibility of malignancy. And this is the first condition. The second common condition that are usually encountered in clinical practice is the Asherman syndrome. Asherman syndrome, it means the presence of fibrosis and adhesions in the endometrial cavity. This results from the destruction of the thick single basal endometrium because of the excessive curation of the uterine cavity for a retained product of conception, for example, following an incomplete abortion or a secondary postpartum hemorrhage. This condition is an irreversible one, and it is an iatrogenic one. However, it can be found in certain medical diseases, especially though those suffered from tuberculosis affecting the genital tract. This figure obviously illustrates how an Asherman syndrome looks like in comparison with a normal healthy uterus. As you see, there is an extensive fibrosis inside the uterine cavity. Of course, the presentation will be a reduced or absent menstrual shedding because there is no endometrium, because as you know that from this basal layer the endometrium usually regenerate, and the shedding happens during each subsequent month. Therefore, if there is no regeneration of an endometrial layer, there will be no shedding, and of course the mens will be absent or even reduced. Treatment, of course, it is difficult because it is an irreversible destruction of this layer. However, the adhesions that are present can be lysed using the hysteroscope. Therefore, the mainstay of a treatment is a preventive. That is to say, the curettage should be done carefully with an experienced operator, and any excessive curation of the endometrial cavity should be avoided. A third common condition, that is a third common benign disorder that is most frequently encountered in those women aged above 40, especially around the age of 45, is adenomyosis. What is adenomyosis meant? It is a benign invasion of the endometrium into the myometrium. But both endometrial glands and cytoma and endometrial cytoma must be present in order to diagnose the presence of adenomyosis. This invasion or this adenomyosis may be either focal or diffuse, and especially if it is a diffused one, it results in significant uterine enlargement. And this figure illustrates how a uterus with adenomyosis looks like. As you see, the one on the right is a one with adenomyosis in comparison with a normal healthy uterus on the left side of this figure. And as you see from this figure that there is a significant difference in the size between both uteri. Clinically, how a woman with adenomyosis presents? Usually, it presents with a heavy mens, with menorrhagia. The blood loss per one cycle will be larger than the expected loss per month in a normal healthy woman. As well, she might suffer from significant dysmenorrhea. And as I said, this condition is characteristic of those who are above their 40s, that is to say in their fifth decade of life, especially around the age of 45. And one of the most important things to remember is that this disorder is rare in nulliparous women, and it is seen less frequently in smokers. How it can be diagnosed? The definite diagnosis is normally done by histological examination of a uterus after hysterectomy, while MRI has been shown to be more accurate than ultrasound in diagnosing adenomyosis before proceeding to surgical intervention and sending the sample for histopathological. What about the treatment? How adenomyosis can be treated? Starting from the first line method of a treatment, this includes simple medications. These are the antifibrinolytics, for example, that are known as cyclocaprons, or using the non-steroidal anti-inflammatory drugs, for example, Ponistan, or by using the combined oral contraceptive pill. As well, a high dose of progestins can be of benefit. The second line will be the use of a levonorgestrel releasing intrauterine system that is known as the Mirena. Mirena, it has been shown that it is effective for the reduction of uterine volume and relief of symptoms up to 1 year of its usage, but its efficacy declines with time. And of course, the third line of treatment that provides the permanent cure for the problem is by doing hysterectomy. That is to say, by doing or performing the surgical option of treating this disease. Now I will talk about the commonest benign tumor of the female genital tract, that is to say the uterine fibroids. Another name they are known as uterine leiomyomata, from which they arise. They arise from a neoplastic transformation of a single smooth muscle cell. Grossly, they appear as a well circumscribed, firm tumors with a characteristic white rolled appearance on cross-section. They usually look paler than the adjacent normal healthy myometrium, and they vary in their size, and there is usually very sharp line of demarcation between the tumor and the adjacent normal myometrial muscle. They are partly dependent on ovarian steroids in their growth. In another way, that is to say, they grow during the reproductive age group until the age of menopause, until the menses is stopped, after which they either cease to grow and even becomes smaller in size. That is to say, undergo shrinkage. This figure is represents a sagittal view of a uterus with multiple uterine fibroids, of course after hysterectomy. As you see, the size of the fibroid clearly varied from a very small one to a large one. And these are a number of fibroids that are inoculated from the uterus by a procedure known as myomectomy. Now, histologically, you have to know what are the composite of a fibroid. Typically, they are composed of varying proportions of a spindle, the smooth muscle cells, and fibroblasts. And from the previous picture, you can see that they may be single but are commonly multiple. Now, what about their classification? They are classified according to their location into a number of types. The first one is a submucosal one, submucosal fibroids. Here, the fibroid is located adjacent to and bulging into the endometrial cavity. The second type is the intramural one, intramural fibroid, which is located centrally within the myometrium, while the subserosal fibroid it is located at the outer border of the myometrium, that is to say, near the serosa. Pedunculated fibroid is the fibroid that is attached to the uterus by a narrow pedicle that contains the feeding blood vessels, while cervical fibroids are those which arise from the cervix. Parasitic fibroid is a term given to the fibroids that arise separately from the uterus and specially located within the leaves of the broad ligament, and they are thought to arise from an embryonal remnant. This figure represents the different types of fibroids that are classified according to their location. What about the incidence and risk factors? Fibroids affect about 20 up to 30% of women during their reproductive life. There is significant racial differences. It has been found that there is a 2 up to 9-fold greater risk of developing fibroid in Afro-Caribbean women. And of course, as I said previously, that nulliparity is a risk factor for the presence or for the development of a fibroid, uterine fibroid. Therefore, it has been found that there is a marked reduction in the incidence with increasing parity, that is to say, with increasing number of pregnancies beyond the 24-week gestation. Among the risk factors, it has been found that, of course, obesity is a significant risk factor for the development of a fibroid, and independent of the body mass index, smoking has been shown to reduce the risk of fibroid development. Another risk factor, and it is important, is positive family history. That is to say, it might have a familial contribution for its development. Now I will explain some of the commonest conditions, effects that might affect a fibroid uterus. These are the degenerations. Degeneration might present in different forms, either a red degeneration, or hyaline degeneration, and cystic degeneration as well. Red degeneration, this happened when there is an acute disruption of the blood supply to the fibroid, especially during its active growth. That is to say, during the mid-second trimester of a pregnancy. In another term, when the fibroid outgrows its blood supply because of the rapid increment in its size, especially during a pregnancy, this will lead to red degeneration of the fibroid, and usually this presents with sudden onset of pain and localized tenderness to an area of the uterus, and this will be associated with mild pyrexia and leukocytosis. These signs and symptoms typically resolve over a few days. While hyaline and cystic degenerations of the fibroids usually happen when the fibroid outgrows its blood supply gradually. This may progress to central necrosis, leaving cystic spaces at the center, termed cystic degeneration. Okay, finally, another complication or another thing that might happen to the fibroid is the presence of calcification. So it may become calcified, especially in a postmenopausal woman. Rarely, malignancy or malignant transformation or sarcomatous degeneration can occur in an incidence of 1 in 200 or less. Clinically, how a woman with uterine fibroids present. In the vast majority of cases, they are asymptomatic and may be discovered or identified coincidentally. However, they may present with an enlarging firm mass arising from the pelvis, or a woman with a fibroid might present with a menstrual complaint, for example, excessive flow, excessive menstrual loss, that is to say, menorrhagia, with or without dysmenorrhea, or she might have an abdominal discomfort, or she might have a sensation of pelvic pressure or backache, abdominal distension, urinary frequency, especially when the fibroid is pressing on the bladder, or there may be a difficulty in micturition This is especially seen when the fibroid is located in the cervix and pressing on the vesico-urethral junction. There might be bowel problems in the form of constipation, or there might be even reproductive dysfunction. And these will be in the form of either subfertility, especially when the fibroid is pressing or distorting the fallopian tubes, or when it is a submucosal one, preventing the implantation of a fertilized ovum. And as well, it might lead to an abnormal lie of the fetus at term, especially when it is located in the lower uterine segment or in the cervix. That is to say, the fetus might present an oblique lie, might lie in the oblique or a transverse, might have an oblique or transverse lie, instead of being longitudinal, which is the usual in non-complicated pregnancy. As well, it might lead to the development of postpartum hemorrhage, because a fibroid uterus contracts less efficiently than a non-fibroid one. How it can be diagnosed? The diagnosis is often clinically made from the features, from the signs and symptoms that are mentioned above. However, ultrasonography, especially the transvaginal one, is very useful as a first line. But the abdominal one is required as well, especially when the fibroid is large and more than being a pelvic organ. And as well, it is important to exclude the presence of hydronephrosis that might be a complication from a fibroid that is pressing on the uterus bilaterally or unilaterally. MRI, of course, it is an excellent diagnostic method, but it is not cost effective. But however, it can provide excellent visualization of the uterus and ovaries. It can clearly and obviously distinguish between a fibroid and an ovarian mass. This is a TVS, a transvaginal ultrasonographic view of a fibroid uterus. As you see that there is a large fibroid arising from the posterior aspect of the uterine wall. How a fibroid can be treated? Treatment can be divided grossly into three lines, either conservative, medical, or surgical. Starting from the conservative management, this is usually appropriate where the uterus is, the woman is asymptomatic, when the fibroid is present and discovered incidentally. But the woman should be followed up regularly at an interval of 6 up to 1 year for detecting its growth rate, using an ultrasound examination or a clinical examination. What about the medical treatment of the fibroids? These are specially designed for establishing symptomatic relief and not to eradicate the fibroids. The best example, or the famous example of a medical treatment, or the commonly prescribed medication, is the gonadotropin releasing hormone agonist. This is the most established medical option, but are not cost effective because, of course, their price is high. Unfortunately, while they provide a very effective relief they are very effective in shrinking fibroid size, and they provide symptomatic relief. But once the treatment is ceased, the fibroid will regrow to their previous dimensions, and because of its menopausal side effects, they cannot be given more than 6 months, and even can be given up to a maximum of 1 year, but with a concurrent hormone replacement therapy or an add-back therapy, because of their postmenopausal side effects, and the most important of which is the risk of osteoporosis. Therefore, their indication is just prior to surgical intervention, and in women who are unsuitable for surgical intervention, for example, due to medical problems or morbid obesity. The second medical treatment that has been shown to be effective in shrinking fibroids at a low dose is the mifepristone, which is an antiprogestin. But this is currently not available for use as it causes endometrial hyperplasia. The third medical example of drugs that are used for treatment of fibroids are the Mirena, that is to say the levonorgestrel releasing intrauterine system. This is especially indicated when the uterus is not more than 14 weeks in size and in the absence of significant uterine cavity distortion. And this figure illustrates how the Mirena looks like inside the uterus. Of course, this is a way of contraception as well, and it is licensed for use up to 5 years. The third line of a treatment is surgical intervention, surgical treatment, starting from hysteroscopic removal of the fibroid. This is suited for the pedunculated fibroid polyp, as well as for a submucosal one, which are less than 5 cm in diameter and which are where more than 50% is present within the endometrial cavity. Its complication is uterine perforation, visceral damage, especially damage to the ureters, hemorrhage, infection, and fluid overload. The second surgical option is myomectomy, which is the preferred option when fertility is desired. Complications include there is a small but significant risk of uncontrolled life-threatening bleeding, which could lead to hysterectomy intra-op. The second possible complication is rupture of the uterus in labor. That is to say, after removing the fibroid, the woman will become pregnant later on. There will be a risk of uterine rupture, especially when the cavity is breached during myomectomy. The third possible surgical option for treating a uterine fibroid is via endometrial ablation. This is especially provided when the uterine cavity is not too enlarged or distorted, and here, in which case, it may be a successful option. Hysterectomy, of course, it is the most popular surgical intervention and the most common surgical option for treating a woman with uterine fibroid. Hysterectomy and myomectomy can be facilitated by GnRH agonists pre-treatment over a 3 months interval. Why? Because this treatment, as I said, will lead to shrinkage of the fibroid size, reducing its blood flow as well, therefore minimizing the risk of a blood loss intra-op and minimizing the likelihood for transfusion, for the need of blood transfusion. However, the drawback is that the tissue planes around the fibroids may be obscured by this pre-treatment with GnRH agonists, making surgery, especially myomectomy, more difficult to be done. The fifth option for treating a fibroid is uterine artery embolization. This is a minimally invasive radiological technique. The idea behind which is embolization of the feeding vessels to the fibroid, and therefore reducing its size by affecting its shrinkage. And this is done via a small incision in the femoral arteries, and of course this is done performed under radiological guidance using a local anesthesia. Shrinkage of fibroids and reduction in menstrual blood loss will happen in around 50%. And this of course painful, especially usually this procedure is followed by a complication and needs the most important of which is pain. Therefore, opioid analgesia is usually required up to 24 hours post-treatment. This figure illustrates how embolization technique is being carried out. As you see that through the femoral artery, a catheter is inserted up to through the aortic arch into the common iliac, through the common iliac into the internal iliac, and then into the uterine arteries, and where these arteries can be embolized. And of course, these are the feeding vessels for the fibroid. This figure presents or demonstrates the reduction in the size of a uterine fibroid after the embolization technique. As you see, figure A presents the pre-embolization size, while figure B is the post-embolization size. What about the complications? The most common of which is what is known as post-embolization syndrome. This usually occurs 7 to 10 days after the procedure and consists of a flu-like illness, a raised white blood cell count. Another possible complications are the development of fever, the occurrence of infection, fibroid expulsion, and potential ovarian failure. Thank you for your listening. Goodbye.